management. Her areas of interest are cirrhosis and liver transplantation, and she will be talking to us today on clinically significant and treatment.
Hi, good afternoon. So the topic given to me was clinically significant portal hypertension, assessment and treatment. I'm sure all of us, are aware of it. So I'll just talk about a few updates. So the outline for my talk would be what is clinically significant portal hypertension, what is its importance, non-invasive assessment of CSPH, and what is primary prophylaxis in CSPH. Now, just starting with the pathophysiology of portal hypertension, like we know, the portal pressures depend upon the flow in the portal vein and also the resistance that is offered by the vessels. So, portal hypertension essentially, there's increased hepatic vascular tone, there's structural alteration and capillarization, there's planktonic vasodilation, all these leading to portal hypertension. Now, how do we measure this portal pressure? So the ideal gold standard, as we all know, has been HVPG, that is hepatic venous gradient. So HVPG is the wedged hepatic venous pressure minus the free hepatic venous pressure. Like we all know, the normal values are 3 to 5. So what is clinically significant portal hypertension? So when the HVPG is more than 10, when the HVPG is more than 10, that is known as clinically significant portal hypertension. Why is it important? Because it is beyond this cutoff, we say patients start developing complications like variceal bleed, ascites, and further decompensation. Hence, this entity of CSPH is important for us as clinicians to know. But what is the problem of HVPG? It is expensive, it is invasive, you need a specialist to do it, you need infrastructure for it. So again, this is a familiar slide, which all of us would have known. We know that in sinusoidal and post-sinusoidal hepatic causes for portal hypertension, there is increase in HVPG. In prehepatic causes, HVPG is usually normal. Now, this is just to show this various stages of liver disease. So this is the D-amico staging that came in 2019. On your left is compensated cirrhosis. So this group is compensated cirrhosis. On the right side, we have decompensated. So there are 6 stages. Actually, it's a continuum. Liver cirrhosis is a continuum going on from fibrosis at various stages going on to cirrhosis. So we have this group, which is important that we identify this compensated cirrhosis. Why is it important? Because if we find this group, we can actually prevent progress of cirrhosis. We can prevent the first decompensation, that is, prevent them from going into this state, that is bleeding or ascites formation. Now, this state 1, state 2, there's a new term that's been introduced. It's known as CACLD. So that is compensated advanced chronic liver disease. Okay, so this stage is important because 60% of those with CACLD actually go on to actually have clinically significant portal hypertension. So that is why the need to find this group. All these groups come to our OPD actually, hence the need to identify them. So what is, again, the importance? Beyond this HVPG cutoff of 10, every 1 mg rise in HVPG will have decompensation rate increase by 11%. You can see the last 2 slides here. So compensated cirrhosis without a CSPH, the 1-year mortality is 3%, as compared to 7% when a patient has CSPH or clinically significant portal hypertension. So this is just to show you on the y-axis, we have free of clinical decompensation. This x-axis is the year of follow-up. The blue line is patient who has a HVPG less than 12. The red line is HVPG more than 20. This is just to highlight patients who had a higher HVPG had higher decompensation. Thus, we need to find the group which is early, who come to us early, where we can actually intervene and prevent this decompensation. Now, how do we assess this group with CSPH? So patients who are suspected to have CSPH, the gold standard, like we know, is liver biopsy or HVPG. But as I again said, both are invasive tests and they are expensive tests. So what can we do? So there are some plasma biomarkers. Most commonly that all of us know are platelets, APRI scores, AST, ALT ratios, Then there is VWF, which, as Vijay pointed out, in various liver conditions, VWF is known to predict in-house survival. So these are certain plasma biomarkers. Now this group, LSM is liver stiffness measurement. Now this is something where most of the cirrhotic studies are based on LSM monitoring. So it is important for us to know what is LSM. Now SSM is splenic stiffness measurement. Again, like how we measure stiffness of the liver, it's measuring the stiffness of the spleen. That is a direct marker of the portal pressures. So this slide just highlights what I told. So there are certain serum biomarkers that can be used for non-invasive evaluation. Most common ones I already mentioned. So APRI-score, FIB-4 all these are available as apps on our mobile phones. So these are a few studies from our department on VWF in liver disease. As I said, there is a direct correlation between severity of liver illness and rising VWF. Now let me come to this transient elastography or fibroscan. I'm sure all of us would have heard about this fibroscan as an entity. Many might have seen this report being brought to our OPDs, but we may not be able to interpret what does this report says. So what is fibroscan? It's a machine where you mechanically induce shear wave. Now this shear speed is calculated as the liver stiffness. Now this is a picture of a fibroscan. It's there in our OPD. This is just to show you that it is a very small, a portable machine. It's a point of care machine and it is done by our registrars and nurses. Till date, we've done around 3,000 over the last 6 months. And it gives you a value in hand within 5 minutes. And it helps you prognosticate patients with clinically significant portal hypertension. So this is how a report looks like. Now, I would just like a few seconds to tell you how to interpret this report. How do I operate this? Doesn't work? Okay. Okay. So this is just to show you, if you can see that the number in the red, this is known as the E value or the elastography. So E value is in kilopascals. E value tells you the liver stiffness measurement. On to the left is the CAP or the controlled attenuated parameter, which tells you the level of steatosis of the liver. So the two things that we have to look at is the E value and the CAP value. On the right, there's also an IQR value. An IQR less than 30% tells you that inter-observer variability is less and your fibroscan report is probably accurate. We take around 10 measurements. So this is the INASL cutoff for fibroscan measures. So anything less than 8 rules out significant fibrosis. More than 8 is F2 fibrosis. More than 9 is F3 fibrosis. And beyond 13.6 is F4 fibrosis. Again, there are multiple studies which have validated fibroscan use in patients with liver disease. Now, this is an important slide. This is from Bavino 7. These are the recent guidelines that came in 2022. This is known as Rule of 5. So it's 5, 10, 15, 20, and 25. Anybody with fibroscan values less than 10 excludes CACLD. Anybody with levels more than 25, assume that this patient has clinically significant portal hypertension. So anybody between, so again, if your fibroscan value is less than 15, patient has a normal platelet, again, you can be sure that this patient's liver is not too bad. You don't have to worry. This excludes CSPH. The next thing I would talk about is splenic stiffness. It is something which is coming up newly. There are more studies that are being done on this. So why do we do this? So there is liver stiffness that increases. There's increased portal flow. Increased portal flow causes architectural distortion in the spleen. Spleen stiffness goes up. So this is a direct measure of your portal pressures. So there are more studies that are needed to validate this method of measurement. So this is just an algorithm for the diagnosis of CSPH. So as I said, anybody with an LSM value of less than 15, of more than 15 is CACLD. Now in this group, how do we find who is CSPH or clinically significant portal hypertension? If they have varices, it is confirmed CSPH. No varices, if the patient has less than 15, normal platelets exclude CSPH. More than 25, again, patient has CSPH. So what are the goals of therapy? Again, I'm coming back to the same slides. Liver cirrhosis is a continuum of illness going on from compensated cirrhosis to death. So we are looking at this group of compensated cirrhosis. What is the goal of therapy here? First goal would be to prevent CSPH. How can I prevent CSPH? Once it is here, how do I prevent this patient from developing the first decompensation? So this is just to tell you that we've been saying that as HVPG goes up, the decompensation increases, mortality increases. However, there is an exclusion, and that is with patients with NCIPH or non-cirrhotic portal hypertension. In this group, HVPG may be normal. Patients may have variceal bleed, but the mortality is not bad. The survival is actually good. This is a study from our center where we said patients with varices, which were non-bleeding or bleeding, survival was 100% in both 1 year and 5 years. So this is an exclusion. So what are the goals? Goals would be regression or reversal of cirrhosis. If not possible, prevent progression. So with this, I come to beta blockers in cirrhosis. Now, how does beta blocker work? So it has beta 1, beta 2 blockade and alpha blockade in drugs like carvedilol. So there's beta 1, beta 2 and alpha. Now this alpha blockade decreases intrahepatic resistance. That is why now when we look at propranolol versus carvedilol, most studies are saying that carvedilol may be a better drug to choose, which may prevent hepatic decompensation as well may prevent a bleed. So this is a landmark trial which is quoted by all. This is known as the Predisky trial, came in Lancet in 2019. Here they took a group of 201 patients, gave beta blockers to one, placebo to one. They took mainly CTP-A, CTP-B patients, that is compensated cirrhotic patients. What did they show? So the blue line is the placebo group, the red line is the beta blocker group. They showed that the patients who had lesser decompensation were in the group that got beta blockers. This study actually said beta blocker is not only used as a treatment or a secondary prophylaxis for a bleed, but is also used to decrease decompensation. It can be used as a primary prophylaxis. Now, this is just to summarize the guidelines for primary prophylaxis. Just to simplify it, anybody with an LSM value of less than 10 is not CACLD. You do not require to give primary prophylaxis. Normal LSCM, varices are present, think of NCIPH, give this patient beta blocker. I'll come to 10 to 15. 10 to 15 suggests CACLD. There is a risk for CSPH. If there are varices, give these patients beta blockers. Again, as the LSCM goes up, 20 to 25, it is CACLD, it is clinical portal hypertension. These patients, if there are varices, give. Beyond 25, irrespective of anything, give beta blockers. Now, beta blockers, as I said, carvedilol is the preferred drug. It decreases decompensation as well. So this is known as the window hypothesis for giving beta blockers. Too early may not be beneficial. Too late, again, may not be beneficial. So finding the right window, LSM, I think, helps us in finding this right window to give the beta blockers. Now, patients who show improvement on LSM, actually LSM monitoring, 20% increase in LSM predicts worsening. This is as per ASLD guidelines. Other things that we can do. So we talked about beta blockers. Second would be etiological management. So a patient with hepatitis B, treating them with antivirals, hepatitis C, treating them with antivirals, can actually improve this patient's liver fibrosis. Or in an alcoholic, stopping alcohol, in a diabetic, weight control and obesity management can decrease decompensation. Now, these are other drugs which I've just put out. There are not too many studies, but few things. One is statins. Simvastatin has been shown that it may decrease portal pressure. Again, we need more data for this, but however, if patient is on statins, low dose statins should be okay. Aspirin should not be discouraged. It decreases. There are a few studies which have shown that it may decrease liver-related complications. If there is an indication for giving anticoagulants, again, it should not be discouraged. It may reduce liver-related events. Take-home message is finding this group called CACLD, finding CSPH in our OPD setup. HVPG, though, is the gold standard. Non-invasive tests help us in finding this group. Fibroscan and LSM helps us in this. And we also looked a little bit with primary prophylaxis in CSPH and role of beta blockers in patients with CSPH. Thank you.
Thank you, Dr. Asisha. Our next speaker is Dr. Apu, who will be